girls. This is Sam from Aspire, OSCE. I just thought that we'll start a series of quickly revising all the Green Top guidelines, and we'll randomly choose the guidelines. I just wanted to show you that this is how I kind of prepare my guidelines after one reading. Okay, so I kind of pick up the important points from the guideline, and I either manually write on my printed document, or I copy paste after summarizing, after making some bullet points, or making some shortcuts like some arrows and equations like this, and I copy paste them on the front page, and then I try to sometimes add another page to summarize all the guidance there, but I keep it with the guideline. That helps me because I'm not a kind of a person who can make my own notes and then trust them in the long run, because I always want to go back and see, whether the guideline actually used the word consider, or whether they said recommend, or whether they said should, or whether they said may. So for me, the reliability is utmost importance, because, especially for part 2 preparation, because the answer varies so vastly between, these kind of phrases like, where is something recommended, or is something allowed, like maybe or could be, or something like that. So based on that, I tend to keep my notes like this with the main guideline, so I can refer back to them instantly, immediately, rather than I'm feeling confused how I should do this. So let's quickly jump to this ovarian hyperstimulation syndrome guideline. This is Green Top Guideline number 5. Okay, I think it says 5 here. Okay, so Green Top Guideline number 5, and okay, so here are my points. They will feel, of course, they are, random. They're not like you're reading the guideline from A to Z. They could be things that, randomly picked from several pages, but they're all very important things. So please don't get annoyed and don't get confused, because they're all very relevant points. Okay, so early ovarian hyperstimulation, these points you must know for all your part 2 exam, and some points would be useful for part 3 exam as well, for the OSCE exam. Okay. Here we say that early ovarian hyperstimulation syndrome usually happens within 7 days of HCG injection, and that kind of indicates excessive ovarian response, and late ovarian hyperstimulation syndrome typically presents 10 or more days after the HCG injection. Okay, and that is a result of endogenous HCG production. This is the difference, and this difference, you will see that this difference even is useful in the OSCE examination as well. Okay, in the OSCE examination, the patient may present in the early days, and if you know this and if you remember this, you'll be able to point out that this is because it has happened within the 7 days. So this is most likely to be a response to the hormone that was given. So it's not really the endogenous hormone secretion that's happening, by which we mean that we have a hope that this will settle soon as well. Okay, exogenous, there's a hope that it will settle soon, and endogenous, that's more likely to cause ongoing problems, and it would be more severe. Then we are saying that combined incidence of moderate or severe OHSS varies from 3.1 to 8% of the IVF cycles. Okay, that's moderate to severe, and mild is present in 1/3 of the cycles. Please remember, this can be, this can be a part 2 question. Okay, so moderate happens in 3 to 8. Okay, 3.1 to 8 means 3 to 8. Almost. So, and mild happens in 1/3 of the cases, but these are of IVF cycles. We are not talking about generally for all the pregnancy. We are saying it happens in these many IVF cycles. Okay. Then we need to know that there is a reporting that's required. Reporting is mentioned that is required for severe or critical OHSS. Okay, national guidance would be that severe or critical are the ones that should be reported. So other than the severe or critical, the reporting could be just local, just to the department. Okay, so that could be important for the OSCE point of view. From part 2 point of view, we need to know that severe or critical will need to be reported. Okay, so and who do they who do we need to inform is the Human Embryology and Fertilization Authority. So HIFA, we call them. I know it's like HFEA, but this is usually called HIFA. Okay, so they require that all incidents be reported within 12 working hours verbally. Okay, 12 working hours verbally, and then it should be followed by a completed incident form within 24 working hours. So verbal information should be provided to HIFA within 12 hours, and then a completed incident form should be reported within 24 working hours. Now here I've written these points which are important, that in severe ovarian hyperstimulation, what happens? So severe ovarian hyperstimulation syndrome demonstrates hypovolemia, typical loss of 20% of the circulatory volume in the acute phase, and accompanies this hypovolemia is reduced serum osmolality. Okay. So these, they say, is a paradoxical combination. Why is it? So you could go and read, but that won't be important really from your point of view. You just need to know that in severe ovarian hyperstimulation syndrome, there is hypovolemia. It's typically loss of 20% of the circulatory volume in the acute phase. Okay. And along with this, if there's a question which says, talks about sodium, then you remember that it's related to is associated with reduced serum osmolality, okay, and reduce sodium. So then we say here that increased risk of ovarian hyperstimulation syndrome is seen in when there's a previous history of ovarian hyperstimulation syndrome, and there's polycystic ovarian syndrome, and in women who had increased antral follicular count or high levels of anti-Müllerian hormone. So these patients will have higher risk of having ovarian hyperstimulation syndrome. So who, again, we can repeat that these are previous history of ovarian hyperstimulation syndrome, polycystic ovarian syndrome, increased antral follicular count, like overstimulated ovaries producing too many antral follicles, and high levels of anti-Müllerian hormone. Okay, so these are associated with this. And we need to remember that this condition is happening because the ovaries are hyperstimulated and they are releasing the inflammatory mediators, which are making the vessels leaky and causing all sorts of problems. Okay. They say that there can be unusual neurological symptoms even after several weeks of ovarian hyperstimulation syndrome. And if you see unusual neurological symptoms, you think of VTE, suspect VTE, okay? So then we say that then we can come to this table. I've tried to simplify the table that they've given in the clinical features, because I've tried to make it easier. Okay, so mild would be when the patient presents with bloating and abdominal pain. That's like mild to moderate abdominal pain. So bloating and mild abdominal pain, let's say, okay, and the ovaries are still less than 8 centimeters in size. Okay, so bloating, pain, and ovaries are less than 8 centimeters. That's mild. Okay, in moderate, there's then nausea and vomiting. So you remember, when there's nausea and vomiting, that's not mild then. Okay, so there's nausea and vomiting, and then there's moderate pain. There is not clinical ascites, but there's ultrasound is showing ascites. Okay, and now the ovary size could be between 8 and 12 centimeters. Okay. This moderate, you need to remember these criteria because the management of moderate can be much different from the management of severe and critical, and this can come in the exam, even in the part 2 or part 3, and this is a very important aspect. Okay, we tend to focus more on the severe things, but I can assure you that even a moderate can come as a tricky question. If you don't remember these criteria, you can face problems. Okay, so that's difference between a pass or fail of the question, or that's the difference between, performing well in the OSCE or performing bad in the OSCE. So please remember, when there's nausea and vomiting, is not mild. Okay, moderate pain is moderate OHSS. Ascites, which is not there clinically but is seen on the scan, that is moderate. Okay, and ovaries are now 8 to 12 centimeters. Less than 8 are mild, 8 to 12 are moderate. After that, moderate. And in severe, there is clinical ascites, okay? And not only there's ascites, there could be plus minus hydrothorax. So now water is now spreading, okay? Ovaries, yes, sorry, ovaries are mentioned here, and they are more than 12. Yeah, they are not mentioned in the critical. So yeah, they are mentioned in here, in the severe, that they are more than 12 centimeters, okay? So oliguria is present and is less than 300 ml of urine per day, or less than 30 ml per hour. Okay, there is hematocrit, which is more than 0.45. So when the hematocrit is above 0.45, that will be severe, okay? Because in critical, it would be more than 0.55, okay? So it's more than 0.45. Sodium is now less than 135 and potassium is more than 5, okay? Sodium derange, potassium derange, sodium decrease, potassium increase. And serum protein could be less than 35 grams per liter, because we are talking about leaky vessels, which is also pouring out proteins. Not only fluids, proteins are being poured out. So the protein in circulation is reduced. Okay, this leaky protein will actually be causing the migration of, and the sodium, of course, will be causing the migration of fluid from the intravascular compartment to extravascular. Okay, so what are we saying here? And probably they could be. Yeah, okay. So here I want you to again remember, compare, and because this table is not only one question, it can be much more than that. Like it can be more than one question based on this table alone, okay, if they've included OHSS. So we are wanting to make sure that we know that when there was no nausea and vomiting, there was mild pain and the ovaries were less than 8 centimeters, we would say that this is mild. As soon as we saw that the nausea and vomiting is present, pain has become moderate, but the ovaries are 8 to 12 centimeters, not more than that, that would be moderate. And the ascites is ultrasonic and not clinical, that is moderate, okay? And in severe, if we keep looking here, what do we see here? That this moderate pain, of course, this will become severe. Whether they say it or they don't say it, we can understand that moderate pain, it will be more than moderate pain. And the ultrasonic ascites will have become clinical, and the ovaries are more than 12 centimeters. That will make it severe. Okay, what else would you find? That because we said the ultrasonic ascites is now clinical ascites, then you can think of that where else can be water. Okay, so plus minus hydrothorax, so you've got water here, and ovaries are, as we said, more than 12 centimeters. Now, because of this ascites, this clinical ascites, there will be, and of course, then intravascular changes as well, there will be oliguria, okay? So, I mean, that can be because of the pressure of the ascites on the renal vessels, and they can be because of the changes in the intravascular compartment on the whole, changes in the osmolality and all that, and various body mechanisms stimulated there. So there will be oliguria, less than 300 ml per day, and less than 30 ml per hour. Don't try to confuse yourself by trying to calculate this many in a day and this many in an hour. How did we reach that? This is just that they've given this criteria. You just need to know this is actually easy. For a day, they've said 300, and for an hour, they've said 30. Okay, hematocrit. Now the blood is thickening. Okay, so hematocrit is increased. It's more than 0.45, and sodium is decreasing, less than 135. Potassium is more than 5. Serum protein is less than 35. Okay, so Now we come to the critical ones. Critical ones, we've got 10 societies now, and the hydrothorax that was plus minus is now large hydrothorax, okay? And hematocrit is higher because the blood is now much more thicker, and the contributing factors are also white blood cell count, which is actually the white cell count might be raised because of the thickening of the blood, and it could be raised because of those inflammatory mediators that are being released from the ovaries, that they might be stimulating some response there as well. Okay, and we saw that there was oliguria here, so now the oliguria / anuria can be present. Okay, and this situation can lead to VTE and acute respiratory distress syndrome. Now we need to remember that outpatient management is justifiable for mild and moderate ovarian hyperstimulation syndrome, and in selected severe ovarian hyperstimulation as well. Okay, so we don't tend to get overexcited and start admitting these patients. And one thing that I could think of is that she has already we don't need to really increase the load of the NHS admitting all the patients that can be managed safely at home, and actually the admission could probably reduce their mobility, and the patient who's got this kind of thick blood risk of venous thromboembolism, admitting will actually reduce their mobility, worsen their condition, and end up in far higher risk of thromboembolism. So I think to keep them mobile, it's a better idea as well. So just remember that the guidance says that mild to moderate ovarian hyperstimulation syndrome can be managed as outpatient, and in selected severe ovarian hyperstimulation syndrome as well, the management can be outpatient management, which will mean that we will keep monitoring with whatever symptomatic treatment we need to give, and whatever bloods and investigations we need to do, okay, and scans or and the measurement or telling them the red flags of worsening, just keeping an eye on whether they get much more edematous and much more symptomatic or breathless and all that. Okay, these patients are advised to drink to thirst. Okay, in those patients who are seen in outpatients, they are reviewed every 2 to 3 days. Okay, and this will be likely adequate, reviewing every 2 to 3 days. But if you think that you should review, more frequent, then that's not a problem. Okay, and they are told to report urgently if the situation seems to be worsening, if the symptoms seem to be worsening. Okay, even they're saying that outpatient management is so organized or so well dependable and reliable in these patients that even those patients who need paracentesis, they can have on the outpatient basis as well. Okay, and it can be done transabdominally or transvaginally. Okay, so just remember that need of paracentesis doesn't even mean, even that doesn't mean that she will need admission. That can be done on outpatient basis. Okay, so after baseline tests in the outpatients, they're saying that repeat the labs if the severity is of OHSS is thought to be worsening. And the combination of elevated hematocrit and reduced serum osmolality and sodium is indicative of ovarian hyperstimulation syndrome. Whenever there's a doubt in the diagnosis, then you'll see that hematocrit is being elevated and sodium and serum osmolality is falling, then you will this will help you in the diagnosis of OHSS. If the patient is diagnosed as OHSS, you avoid non-steroidal anti-inflammatory drugs as they can compromise renal function. Okay. Then who gets low molecular weight heparin? So all the inpatients will get low molecular weight heparin. Okay, and they say that assess the risk in case of a moderate OHSS as well. So who are the inpatients? So inpatients are mostly the severe and the critical ones. Okay, sometimes we only will offer admission to any moderate OHSS only if they cannot take care of themselves at their homes. Okay, so that is something for the part 3 candidates to remember. Okay, so if they don't have any support at home, they're struggling, they live very far from the hospital, and if something goes wrong, if there are red flag signs, they won't be able to reach the hospital, just like we do, you know, in case of red flags that we tell to the ectopic pregnancy as well. So, you know, distance from the hospital, whether they've got support or not, all those things will matter. Now, so other than that, if the patient is has severe OHSS and is being treated outpatient basis, they'll need a low molecular weight heparin as well. And there are some moderates based on their risks, like they may, whether admitted or not admitted. Okay, so most of the moderates will only have stockings, but some may need low molecular weight heparin. Now let's see MDT. So MDT should be who requires MDT. There can be a question about, you know, that this is the patient, and then you might need to you know, you might need to assess whether she falls in, you know, category of mild, moderate, or severe, or critical. And there may be a question whether she needs MDT. So MDT is required for critical OHSS and severe OHSS with persistent hemoconcentration and dehydration. So these are the two who would require MDT care. Okay, and also they say that for critical ovarian hyperstimulation syndrome, we should be managing that patient with MDT while consider ITU care for this patient. Okay, for critical, MDT is a should and ITU is a consider. Okay, now that doesn't mean that I'm not saying that if moderate OHSS comes to you in the OSCE exam, then you don't mention MDT. We still say, you know, MDT there, but here the guideline says that you will definitely need in cases of critical. Okay, critical and some severe. Fluids, we start with the oral fluids, you know, preferably we start with the crystalloids and then we move on to colloids. And if there is persistent hemoconcentration present, then invasive monitoring will be required, and anesthetic input will be required. Okay, so this is the management of the fluids, that we start with the oral. Oral means that, you know, she should drink to thirst and all that. Okay, and depending on her dehydration levels, we'll give her crystalloids, and then colloids, and then persistent hemoconcentration will mean that she will require invasive monitoring and anesthetic input. And with oliguria, we need to remember whenever there's a question about oliguria, we say avoid diuretics. Okay, so in oliguria, diuretics are not the, you know, the first thought that should come in our mind, because there is a different reason for that oliguria. So we treat the oliguria with oral fluids, crystalloids, colloids, and then we think about, if the oliguria is not corrected with these, then we think about draining the ascites. Okay, and if the oliguria is persistent, then diuretics may have a role. So diuretics will have a role after we have already, you know, tried to drain the ascites. So if this is an EMQ, you'll need to remember this kind of sequence, because, you know, they always ask what's next and things like that. So you remember that first you will manage by managing oral fluids, then switching to crystalloids and or adding crystalloids and then colloids, and then you'll need to drain the ascites. That will be the next step towards, you know, trying to help her with her oliguria. And then if it still persists, then there will be a role of diuretics. Okay, and then let's talk about the parasynthesis. Okay. Yeah, we'll talk about this later. So let's talk about parasynthesis. In parasynthesis, we say that, let me scroll this up. So, okay. And just give me a second, please. Okay. So I don't want you guys to be distracted, because there's a lot of color that I use. So I want to keep you guys on the point that I'm talking about. Okay, so paracentesis, when do we use paracentesis and how and where? So we talked about where. We said it can be done as outpatients, and of course it can be done in patients as well, but it's a possibility that this can be done outpatients as well. Then it can be done transabdominally or transvaginally. Most people avoid transvaginal route because you don't want to be giving her ascending infection or something like that when she's already, unwell. So most people don't prefer transvaginal route. Transabdominal is the preferred route usually. And when do we do? What are the indications of paracentesis? So severe abdominal distension and pain secondary to ascites. That would be very, so if the pain is severe, if the patient is short of breath because she was holding a lot of fluid in her tummy, okay, so respiratory compromise secondary to ascites and increase intra-abdominal pressure, then you relieve her pressure to help her with her shortness of breath, and oliguria despite adequate volume replacement secondary to, again, increased pressure and reduced renal function. So what are the three things then? So we have pain and can't breathe because of all that pressure and not urinating, not passing adequate urine, again because of lots of pressure. Okay, we always do it with ultrasound guidance. Okay, and replace the fluid, okay, if the large volumes are being drained. So give her colloids if large volumes are being drained, otherwise it will keep forming again. Okay, so if anyway still keep forming, but to make sure that to reduce, let's say, to reduce the speed of pace of reforming, we give her colloids. Okay, so for her intravascular and extravascular fluid balance kind of. Okay, so let's come to the next page of my notes. So on this page, actually, this is a duplication mostly of my previous page. So, but here there are just two more important points that I like to mention. One is that as we said that 1/3 of the patients get mild hyperstimulation syndrome after IVF. There's one important thing that 0.7 to 10%, like you can say 1 to 10% if you want to round this up, 1 to 10% of the patients will get thrombosis. Okay, so VTE risk, how much is a VTE risk? If there's an SPA that asks you this, then about 1 to 10% of the patients are at risk of having thrombosis. Okay, and in women at risk of ovarian hyperstimulation syndrome, when they were offered telephonic follow-up and outpatient monitoring and paracentesis, so when they were dealt with on an outpatient basis, as I was talking to you earlier, that this is a very important strategy because it does reduce our hospital admissions to half of what would be if they had to admit all the moderate to high severe OHSS patients. So what they're doing is that moderate to severe cases, they are offering them telephonic follow-up, like outpatient appointments and then telephonic follow-up. And then if paracentesis is required, it's done on an outpatient basis. If they do that, the hospital admissions get reduced from 8.4% to 4%, which is like less than half. Okay. So that's that can again come as an SPA. Okay, so anything else on this page? Not really. So we have covered lots of points here. Okay, so yes, we have covered. I was just going through to see if there is anything left. Apparently, we have covered all from this page as well. Okay. These are the tables from which I extracted this simpler table. Okay. And these are very important tables for all of us to go through for part 2 and part 3. Examination of and investigation of women with suspected OHSS. What does it involve? So general examination, you assess for dehydration and edema. Edema would be edema, ankle edema, like pedal edema, vulval edema, sacral edema, and you record the heart rate, respiratory rate, blood pressure, and the body weight. And abdominally, you assess for the ascites and any palpable mass and any sign of peritonism, and then measure the girth of the abdomen. In respiratory, you assess for the pleural effusion and pneumonia and pulmonary edema. Okay, so these are the examination points that are important. Then investigations important investigations would include full blood count, hematocrit, CRP. CRP will tell you about the severity. Urea and electrolytes will indicate hyponatremia and hyperkalemia, and serum osmolality will show hypoosmolality, and liver function tests which will indicate elevated enzymes and reduced albumin. Elevated enzymes, we tend to sometimes forget these, but please remember, okay? Coagulation profile, you'll find elevated fibrinogen because the blood is too thick now, and it's like it's intravascular dehydration, isn't it? And reduced antithrombin as well. Now, HCG, you do to determine the outcome of the treatment cycle if it's appropriate. So we need to, if it's relevant, because she is OHSS, whether she's already been given the, the embryos have been replaced or not, depending on that. Ultrasound scan to see ovarian size, pelvic and abdominal free fluid, and ovarian Doppler if you are suspecting torsion. Because these ovaries become so big and these patients present with pain, you want to see whether the pain is just because of capsular, in ovarian tissue, ovarian enlargement and capsular stretching, or is it because of torsion, okay? So, because they can be very painful without the torsion as well, and they are at very high risk of torsion, okay? So these will constitute your investigations. I'll quickly repeat: full blood count and hematocrit, CRP, urea electrolytes and LFTs, remember them together, and serum osmolality, coagulation profile, and HCG and ultrasound scan. Other tests may be indicated could include arterial blood gases, D-dimers, echo, and ECG, and chest X-ray, and CTPA and VQ scan, when you're suspecting that this woman is now having some, VTE/PE, okay? So anything from here? No, we have done this, we've covered this, and we have covered this, okay, so thrombosis in women, this is important, okay? Let me bring you to these points, okay? So thrombosis in women with the OHSS frequently affects upper body sites and frequently involves the arterial system, okay? So if you are seeing that a patient is complaining of dizziness and loss of vision or pain in the neck or something like that, then you will need to remember that these patients can have unusual symptoms. Okay, so always remember in OHSS, don't forget that these patients can have unusual symptoms like neck pain, loss of vision or dizziness, okay, and upper body thrombosis, okay. What else? So persistent hemoconcentration or low urine output despite adequate volume replacement, we already said that you treat with colloids. And okay, it says MDT assistance, but we also need to remember that, of course, do some paracentesis to relieve her, okay, to relieve that ascites. And avoid NSAIDs, we said that it causes renal damage, and human albumin solution 25% may be used as a plasma volume expander. This is an important point, okay, because in UK, this can come as an SPA, okay, or even as an EMQ. They can ask which fluids, okay? So colloid HES has been withdrawn in the UK, okay? So was showing some increased mortality in critically ill and septic patients compared to the crystalloid. So this HES is withdrawn, and human albumin solution, so HAS, okay? This 25% may be used as a plasma volume expander. Any death, we said that it must be reported to Embrace UK, irrespective of whether the woman was pregnant or not. So these are, here I've covered all the important points that I think were relevant to this guidance. I'll quickly scroll down to see if there is anything else in the guidance that's standing out. Okay. So as we were talking about, who needs to be admitted, I already said that if the patient is unable to attend for regular outpatient follow-up, then we can consider admission in her case. Okay, so there's nothing new here. We've already covered this. So these patients may be at an increased risk of preeclampsia and preterm delivery. Please remember, okay? Surgical option will only be included if there is, I think I missed this one, this surgical option. This was next to the paracentesis in my boxes above, and I was about to read it and I forgot that surgery will only be done if there's a coincidental problem such as adnexal torsion or ovarian rupture or ectopic pregnancy. It should be performed, of course, by an experienced surgeon, okay? So, now, I'll again want you to remember that there could be an increased risk of preeclampsia and preterm delivery. Okay, so yeah, so we said that the HCG stimulation, it can overstimulate the ovaries and it can release a pro-inflammatory mediators. But one thing that I want you guys to remember is that women who end up with ovarian hyperstimulation syndrome with exogenous HCG injections, these women can they may have a recurrence of the same if you give the same injection in the next cycle as well, because this is the way they're responding to the HCG. And we probably, most of us know that in this situation, the next cycle would be modified in a way that rather than giving HCG injection, they'll give them progesterone injection for ovulation. Okay, so I don't know whether it's mentioned here or not, but this is something very important. This is especially relevant to the OSCE stations. Okay, so patient may ask you if will I be ending up again and again with ovarian hyperstimulation syndrome, and then you can say that because HCG was used, it's like there's a chance that next time when we change the injection to a different one called progesterone, then you may not, respond in such a fashion, okay? And say that this is linked to HCG injections, not in all patients, and that's why, otherwise, why would they use if it was happening in all the patients, okay? So just something to remember. And then, yeah, so it can happen in all the women, we know that. We've covered this, early when it happens and late when it happens, we've discussed this. And yes, our guidance is done. We have done all of the guideline in our beautiful colored boxes. Okay, so what's this syndrome? Okay. So yes, this is important. This is something that I forgot to say. When I said that NSAIDs should not be used, we need to also remember and emphasize that paracetamol and oral opiates, including codeine, can be offered to women for pain relief, okay? Because these patients will ask you, what can I have? So you can tell them this. Actually, codeine does cause constipation, and with patients whose ovaries are so painful and whose, this may become uncomfortable, should be given with the laxatives probably. Okay, but just remember that she may say that I don't want that because it causes constipation. So remember paracetamol, and then you can always say that we'll get input from MD. This is about OSCE that we can say we'll get input from, other team members as well. So an observational study has suggested that GnRH antagonist administration in women with established severe early OHSS may result in quicker regression of the syndrome. And dopamine agonists may have a beneficial role in the treatment of established OHSS. But this is just something, may and may not. And, this is not something that they are very sure about. So we'll say just may and may not. If you want to remember something like that, I don't think they are going to ask you something like that. But just remember the possibility of this. Okay, so that's it really. We are done with this guideline. I hope this will help you with a quick revision, and I hope you can listen to it whilst going around when maybe driving, maybe doing your laundry. And I hope I have indicated all the important points so that you find yourself as expert in this Green Top Guideline now. Okay, expert in treating OHSS. Okay, so I'll see you sometime soon. Bye-bye. Let me know how it goes and join my Telegram group if you wanted to request some topics that you like. Bye-bye.